We did have a total, at last I checked, of 96 people who had registered. So that's a lovely turnout, especially on such a gorgeous night where, they could be dining outside on Park Avenue or something like that.
Right.
It's always like this little awkward silence as they come filling in, but I don't want to start and not have the different folks hear what we've got for announcements. All right. Well, I will go ahead and get started. Welcome to the Breast Cancer Coalition Evening Educational Webinar. We are thrilled to welcome Dr. Kelly Krupa from Rochester Regional Health to discuss surgical oncology and breast cancer. So just a few things before we begin. From our community partners, Rock Crew, NIAID's Rowing Over Cancer is holding a 2023 National Learn to Row Day on June 3rd, and you've got a choice of 9 a.m. or 11 a.m. This is a free introductory event where you will learn more about the Rock Crew and rowing. You will get to meet some of the crew, tour the boathouse, and practice using the machine, take a brief ride with the crew. And Allie, if you'd be so kind to put the link to the form for registration in the chat, that would be wonderful. Thank you to all who participated and everyone that donated to the Pink and Teal Challenge that was held on May 13th. It's our annual 5K walk run fundraiser to support the Breast Cancer Coalition. We had beautiful weather and enjoyed the MCC campus. Donations are accepted until May 27th, so there's still time to donate. And your donations help fund programs just like this, so thank you so much. The Cancer Support Community at Gilda's Club is holding an evening of bingo and pizza making tomorrow night, May 25th on Thursday. Bingo and pizza will begin at 6, and that is located at their Alexander Street location. And they'll also open early at 5:30 for anyone small children who want to play in their Noogie Land. And there is a way to register that I think Allie will put in the chat for us here. And so about tonight, thank you to those who have submitted questions in advance for Dr. Kelly Krupa. If you have questions during the presentation, enter them into the chat feature for a Q&A segment following the presentation. At any point that you leave the webinar this evening, a brief survey will pop up on your browser from Zoom. Please take a couple of minutes to answer the questions. All of the answers remain anonymous, but they're shared among our coalition program staff and our presenter. This just helps to ensure that programs that we offer are meeting the needs of our community. So please help me welcome Dr. Kelly Krupa. It was wonderful to meet Dr. Krupa last August as she was meeting with community organizations like ours, the Breast Cancer Coalition. Her clinical interests include nipple-sparing mastectomies, high-risk management, and medical education. She focuses on providing compassionate, individualized surgical cancer care and educating patients to ensure they understand their disease and treatment options. Thanks for joining us this evening.
Thank you. My slides. Great. Thank you, Christina, for the introduction. I'm excited to be here tonight to talk about the surgical management of breast cancer. So as Christina said, I'm a breast surgical oncologist, so I'm board certified in general surgery, and I did additional training during a fellowship that focused only on breast surgery. I'm part of the Rochester Regional Health Breast Center, and I see patients at the Unity Hospital and Rochester General Hospital locations. So today I want to briefly discuss breast cancer statistics, go over breast cancer carcinogenesis and the biology of breast cancer, what the general principles of breast cancer treatment are, how we determine the timing of breast cancer surgery, as well as the timing of referrals to the multidisciplinary team. I want to also discuss the surgical options for breast cancer and the considerations of a patient's medical history in our decision-making. So first, this slide depicts from the American Cancer Society facts and figures for 2023. So breast cancer is the most commonly diagnosed cancer among American women and is the second leading cause of cancer death in women. In the United States in 2023, invasive breast cancer will be diagnosed in over 297,000 women, about 2,800 men. So we've seen since the mid 2000s, the incidence of breast cancer in women has been increasing by about 0.5% per year. And this is due to earlier detection and increased awareness. So we're finding breast cancer at earlier stages when it's very treatable. So along those lines, mortality trends have shown that mortality has declined by about 43% since the 1980s as of 2020, again, due to earlier detection, increased awareness, and improved treatment for our patients. So let's see if it lets me go to the next.
Is your arrow button just the right one to use?
Yes, is the bar that has some of the Zoom information, is that viewable, or can you see my full screen?
I see the full screen.
Okay, perfect. So moving on to breast cancer development, this is a heavily researched area right now, trying to determine exactly how breast cancer develops. So in general, carcinogenesis is the term that we use to describe the development of cancer, which is a multi-step process involving the transformation of normal cells to cancerous cells that ultimately leads to the formation of a tumor. Specifically in breast cancer carcinogenesis, we know it's a complex process that's attributed to various mechanisms, including hormone exposure, gene mutations, so genes that may or may not have modifications, all of which dysregulate normal cellular functions. So we used to think that there was one cell in the breast that underwent changes and then from there went rogue and divided and created a tumor. But now we know that it's a lot more complex than that, and probably multiple cells in the cellular environment undergoing changes and dysregulation that lead to this process. So why this is important is because understanding breast cancer initiation, how the cells progress, will lead to better development of breast cancer therapeutics and overall increased survival for our patients. So as far as breast cancer development, we can talk about the anatomy of the breast and where a cancer originates. So in the glandular part of the breast, there are lobules where milk is made and travels through the ducts out of the nipple. About 65% of breast cancers come from the ducts, about 15% from the lobules, and then there are other breast cancers. Ductal carcinoma in situ is the term that we use for stage 0 breast cancer, where the cancer cells are inside of the duct and have not come outside of the duct into the surrounding breast tissue. What's also important to define about the type of breast cancer, besides the location where it has come from, is the subtype in regard to the biology of the breast cancer. So that means the estrogen, progesterone, and HER2 status. We can define at least 4 major subtypes. So estrogen and progesterone, those are circulating hormones throughout the body. In premenopausal women, the hormones largely come from ovaries. And in postmenopausal women, hormones are coming from bone, adrenal glands, fat cells. So we want to know, does the breast cancer respond to estrogen, progesterone, and a marker called HER2? So in luminal A breast cancers, it is very strongly hormonally positive. So estrogen, 95%, progesterone, 95%, HER2 negative. Luminal B breast cancers are still hormonally responsive, but a little less so. So ER may be about 60%, PR could be 0 or negative, and HER2 is negative. The HER2 positive breast cancers, we know that HER2 is a protein that regulates biologic responses, and if there's overexpression, the breast cells grow very quickly. Triple negative breast cancer is the fourth major subtype, and that's where the breast cancer does not respond to hormones or HER2. So estrogen, progesterone negative, and HER2 negative. And this picture in the right corner of the slide shows how a pathologist will determine the type of breast cancer. So different staining of the tissue is performed that will tell us the percentage of cells that are responsive to estrogen, progesterone, and if HER2 is positive. The biology of these subtypes are different, so it impacts our treatment choices and also will give us an idea of prognosis. So it's really important to define the type of breast cancer that a patient has based off of the biology of the breast cancer. Moving on to general principles of breast cancer treatment. So I describe breast cancer treatment on two fronts. One is local treatment and the second is systemic. So locally, that's where I come into play as a surgeon. Also radiation to the breast, which is largely managed by a doctor called a radiation oncologist. Radiation is X-ray beams that are delivered to the breast. Also can be given to the armpit or the axilla region. Then the other hand of treatment is systemic treatments, which is managed by a medical oncologist. So based off of the type of breast cancer that a patient has, a medical oncologist may recommend anti-estrogen medications, chemotherapy, or other targeted medications such as in HER2 positive breast cancer. So again, depending on the type of breast cancer, the systemic treatment or a treatment that goes throughout the entire body, whether in the form of a pill or an IV medication, will be recommended. So how do we know the timing of surgery? So one, there is a Commission on Cancer benchmark that was released last year, almost a year ago, that states that the definitive treatment surgically should be performed within 60 days of diagnosis or the biopsy. So that's a benchmark from the Commission on Cancer. But importantly is again defining the type of breast cancer that a patient has and the stage. So for staging, we're looking at the size of the tumor, if there's any lymph nodes involved. Why lymph nodes are important is because the first place that a breast cancer will go outside of the breast is to the lymph nodes under the arm. So during a workup of staging, I will assess on physical exam if I feel any lymph nodes under the arm that feel abnormal. And also on our radiology imaging, do we think that there's lymph nodes involved? Do we have reason, also part of our staging, do we have any reason to suspect that the breast cancer is outside of the breast? So stage, lymph nodes, is it anywhere else outside of the breast, and the biology. So the estrogen, progesterone, and HER2 status will all help determine a patient's stage. And then once knowing the biology and the stage of the breast cancer, we can decide, should a patient have upfront surgery, proceed with surgery first for their treatment of breast cancer. So on the slide, I have listed what are the considerations to see a medical oncologist first, or to have preoperative neoadjuvant before surgery therapy. So this may allow us to downstage a tumor so that there's more surgical options. Maybe a patient would like to keep their breast, but currently is not a candidate because of the size of their tumor. Also, it gives us information based on the response to therapy. So if a tumor completely melts away with systemic treatment, that's information. We know that that tumor responds to the treatments that we have available. So then along those lines, if the patient has upfront systemic treatment, we do surgery and the tumor is no longer there, well, then maybe we can de-escalate treatment after surgery. Or if there's still some tumor that's remaining, that gives the medical oncologist information on what additional systemic treatment to give. And during that time, it may allow a patient to make a more definitive decision or definitive surgical decision with what they would like to proceed with after they're done their systemic treatment. Also, largely important with neoadjuvant therapy is research studies. That's how the field progresses forward, is doing clinical trials and research. Then kind of broken down into inoperable and operable breast cancer. So at presentation, a subtype of breast cancer that we would recommend to have chemotherapy first, for example, would be inflammatory breast cancer, if there's really a lot of lymph node involvement. For operable breast cancer, again, looking at biology for HER2 positive and triple negative breast cancer, if those tumors are larger than 2 centimeters, or if those subtypes have lymph node involvement, then upfront systemic treatment really should strongly be considered. So this is a very individualized and discussion with the other specialists that take care of breast cancer patients. This is the slide from the National Comprehensive Cancer Network, which basically summarizes what I had on the previous slide. So breast surgical oncology is a very data guideline-driven field, which is partly why I really enjoy my field, is because there's typically data or guidelines behind why we're recommending a treatment for a patient. So this goes over, again, some known benefits. So it may give us more surgical options to have preoperative systemic treatment. It gives us information in certain subtypes, allows time for decision making. And then on the other half of the slide, again, talks about considerations for patients who present operable disease and those that really should proceed with neoadjuvant first. So possible treatment courses that include surgery. So first would be upfront surgery, then proceeding with another local treatment to the breast, radiation, followed by systemic treatment, or surgery upfront, followed by systemic treatment, then followed by radiation, or systemic treatment first, followed by surgery, then radiation, and potentially additional systemic treatment. Usually upfront systemic or neoadjuvant treatment is around 6 months. Radiation courses can be anywhere from 3 to 5 weeks. And adjuvant or systemic treatment after surgery and radiation, those recommendations to continue treatment can be anywhere from 1 to 5 years, depending on the type of breast cancer. I do want to make a note of the surgical treatment of stage 4 breast cancer. So stage 4 breast cancer is where the cancer in the breast has gone outside of the breast and is in another location of the body. So the current data that we have provides little support for doing surgery on the breast or doing surgery on the primary tumor. Studies have not shown a survival benefit or a benefit in improved quality of life. Potentially surgery may be considered if the primary tumor in the breast is progressing, but the distant disease or disease outside of the breast is well controlled on current systemic treatment. So this would be a very individualized decision plan. There are ongoing studies to evaluate which subtypes of stage 4 breast cancer may benefit most from surgical treatment. So for example, a estrogen positive breast cancer where there's only one site of disease outside of the breast, such as the tibia. In those types of patients, would it be appropriate to do surgery of the breast? So there's still ongoing studies to really try to evaluate specifically which patients will benefit. So how do we know when to refer to the multidisciplinary team? As a breast surgeon, I typically see a patient first after they've been diagnosed with breast cancer. So basically all breast centers have a tumor board. So on the tumor board, there are other surgeons, medical oncologist, radiation oncologist, radiologist, pathologist, social work, any provider that's involved in taking care of breast cancer patients to discuss cases specifically to determine a individualized treatment plan for a patient. Also, if a patient meets any of the criteria to be considered for neoadjuvant treatment, they need to be referred to my medical oncology colleagues to have that discussion and see what their options are. Some centers will couple appointments as a new patient. So a patient may see the breast surgeon, medical oncologist, radiation oncologist all on the same day. There really isn't one correct way to do it. Referrals can also be made after surgery if that's appropriate as well. I want to move on to talking about the surgical options for breast cancer. How I divide this is into treatment of the breast and treatment of the axilla. Because again, what's important about the axilla or the armpit is the first place a breast cancer will go outside of the breast is to the lymph nodes under the arm in the axilla. So first is surgical treatment of the breast. I offer two surgeries for the breast. One is breast conservation or lumpectomy. So that means removing the tumor with a healthy margin of tissue. So the tumor is localized in the breast. There are several different types of technologies for localization. This allows us in the operating room to find the tumor with accuracy so that only the tumor with a healthy margin of tissue is removed and there's no denting or cosmetic deformity of the breast. Typically, which we'll talk about, radiation therapy is often recommended after lumpectomy. So I will tell patients that lumpectomy goes hand in hand with radiation. The other surgical option for treatment of the breast is mastectomy, which means removal of the entire breast. And in this case, patients have the options to potentially leave the skin overlying the breast, potentially leaving the skin and the nipple, and having reconstruction to recreate a natural breast, or a flat closure. We've come a really long way in the surgical treatment of breast cancer. On this slide is a picture of Dr. William Halsted, who was a surgeon at Johns Hopkins during the late 1800s and early 1900s. And he is known for his procedure in which he removed the entire breast, overlying skin, the chest wall muscles, with routine sacrifice of the nerves in the armpit, as well as removed all of the lymph nodes under the arm. And this procedure, he named it the Halsted radical mastectomy, which became the standard of care for treating breast cancer until the 1970s. His recurrence rate was much lower than his other surgeon colleagues. And you can see in the picture here, this is a very deforming and disfiguring surgery to have the breast, skin, and all the chest wall muscles removed, as well as all of the lymph nodes under the armpit, creating a lot of morbidity in the form of arm swelling or lymphedema. But with patients living longer and there being more breast cancer survivors with disfigurement and emotional distress, the question was raised, is there a way to get the same oncologic outcome with fewer adverse effects? And that's when in the 1960s, the breast cancer collaborative trial research groups were formed. So I want to highlight a couple of landmark trials. Again, as I mentioned, this is a very data-driven field, and a lot of the time when I'm recommending a treatment option for a patient, there is a data or a guideline behind that. So for example, NSABP B04 in 1971, this study asked the question, Is a mastectomy with or without radiation as efficacious as the Halsted radical mastectomy in patients with early stage breast cancer? And what was found was that there was no difference between the two groups. So a modified radical mastectomy, that was the Halsted mastectomy, was as effective as a radical mastectomy for early stage breast cancer, meaning the skin and the chest wall muscles did not need to be removed. Going a little ahead to 1977, NSABP B06, and this trial, it was asked, can we do a lumpectomy? And in this study, this is where we found a lumpectomy plus radiation is equivalent to a mastectomy. So we move from saying we don't need to do a radical mastectomy to now lumpectomy plus radiation is equivalent to a mastectomy. So if a mastectomy is equivalent to breast conservation, how does the patient decide what procedure to proceed with? So for a mastectomy, anyone is a candidate. I want to make sure my patients understand the data between a mastectomy and lumpectomy that, again, largely goes hand in hand with radiation. The risks of this procedure, so it's a much larger procedure, the risks of the complications of bleeding, infection, need for subsequent procedures is larger. Mastectomy is always an option. For breast conservation or doing a lumpectomy, not everyone is a candidate, so it needs to be oncologically safe. Can we obtain clear margins? Or is there diffuse disease throughout the breast that's not going to be possible and there will be significant deformity of the breast? Can a patient not undergo radiation therapy? Multicentric disease, so that means that there is a tumor in more than one quadrant of the breast. So it looks like in one quadrant, there's one separate process, and another quadrant, there's a separate process going on there. I will say there is a study that's coming out of the Mayo Clinic that is looking at if we do a preoperative MRI and only define disease in, say, two quadrants, and it doesn't seem to be disease throughout the entire breast, this may be feasible. So again, a data-driven field where that recommendation may change, but typically speaking, if there's disease in more than one quadrant, a mastectomy will likely be recommended. Or if the patient doesn't want a lumpectomy. Absolute breast conservation or radiation contraindications. So who really cannot proceed with breast conservation? So a pregnant patient who would require radiation during pregnancy, it won't be recommended. Again, if there's a diffuse process throughout the entire breast that it does not seem feasible to get clear margins. And if a patient has already had a lumpectomy and there continues to be diffusely positive margins on pathology, a mastectomy will be recommended. Patients who have a TP53 gene mutation because of the side effects of radiation and being at a higher risk of developing another cancer, those patients typically are not breast conservation candidates. Relatively speaking, if a patient has had prior radiation to the chest wall or breast, may not be recommended to have breast conservation again or radiation again. A consideration needs to be taken to active connective tissue diseases involving the skin, because that is in regard to radiation, the skin would be radiated. We talked about a persistently positive pathologic margin. So a patient's gone to the OR maybe 2-3 times, and it's looking like there's still cancer left behind. And continuing further would create a large deformity in the breast. And also patients with a known genetic predisposition to developing breast cancer. So commonly talked about are, say, the BRCA1 and 2 genes. Those patients have a 40 to 60% lifetime risk of developing breast cancer. A patient may decide that they want to proceed with a mastectomy as part of risk reduction. Other considerations for a mastectomy Again, I want my patient to understand that the survival is the same compared to breast conservation. And really what's important too to understand is that the surgical treatment does not dictate systemic treatment recommendations. As I kind of showed in an earlier slide, the local treatment options and the systemic treatment options, they are different arms of treatment. So the systemic treatment is dictated by the biology and staging of the breast cancer. So doing a certain procedure will not opt out of certain systemic treatment recommendations. We also want to talk about reconstruction, which I'll talk about in some subsequent slides. Does the patient understand the goals of reconstruction? Can and should the nipple be spared? I wanted to talk briefly about prophylactic mastectomy. So that means removing the breast that is unaffected, so the non-cancer side. This will lower the risk of breast cancer by about 90-95%, but it does not eliminate it. It's not a 0% risk in the future. In the absence of a gene mutation, the risk of developing a new breast cancer in that remaining breast is above average, but it's still relatively low. So again, there's some gene mutations that can give an upwards to 40-60% lifetime risk of developing breast cancer. But patients who are average risk, removing the unaffected breast, the risk of developing a future breast cancer in that other breast is only a little above average. But considerations need to be made if the breast is not removed. Say screening with mammography will need to be performed. Is there a cosmetic consideration for symmetry, for example? And it's also important to note that a prophylactic mastectomy can be performed in the future. So now I want to talk about breast reconstruction. Reconstruction is performed by a plastic surgeon that specializes in breast reconstruction. So for example, I would do the mastectomy portion of a procedure, and then the plastic surgeon would then follow to do the breast reconstruction. And reconstruction is an option for any patient receiving surgical treatment for breast cancer. In regard to mastectomy, this can be performed with a patient's own tissue, so autologous tissue, an implant, or a combination. I also want my patients to understand that in consultation with the plastic surgeon, more than one procedure may be recommended. So a temporary tissue expander in the case of a mastectomy could be placed to allow the skin to stretch over time to accommodate final reconstruction. So sometimes, again, not always performed just in one procedure. And the options for a mastectomy would be skin sparing, so keeping the skin envelope so that is available to recreate a natural breast, and then also nipple sparing, keeping the skin and the nipple. There's also the option for an aesthetic flat closure, which may or may not involve a plastic surgeon. There can also be revisional surgeries performed, such as fat grafting, mastopexy, a contralateral procedure safe for symmetry. There's also the option of 3D nipple tattooing. And any patient not satisfied with the cosmetic outcome of their breast surgery. So whether that is a patient who has had breast conservation or a mastectomy. These are some examples of reconstruction after mastectomy. So in the upper left is an aesthetic flat closure. In the middle, that shows using the patient's own tissue and what's called a deep flap, or a DIEP, because it uses the deep inferior epigastric vessels. So tissue is taken from the lower abdomen, and then that's what's used to recreate the breast. And then the picture shows the patient with that procedure there in the middle. And the upper right is a patient who has had a skin sparing mastectomy. So the skin envelope was left behind, and then the plastic surgeon did reconstruction with implants. The other surgical treatment that we have to consider for treating breast cancer is management of the axilla. And this is another area of ongoing research to see how we can de-escalate surgery in this area. because again, back in the up to the 1970s at least, all of the lymph nodes under the arm were removed. And that led to a lot of morbidity for patients. So lymphedema, arm swelling, nerve damage. And we found that we can actually map the lymph nodes under the arm that drain the breast. So the lymph nodes that are under the arm, not only are they draining the breast, they're draining the arm. And we're only interested in those lymph nodes that are draining the breast. So how we map those is with tracers. So one is a radio tracer, technetium, and the other one is a blue dye. So these tracers will get injected usually next to the nipple or under the nipple, and it travels from the breast to the underarm. And at the time of surgery, we can remove only those lymph nodes that take up the radio tracer and the blue dye. And then those are sent to pathology to see if there's any cancer in the lymph nodes. And that aids us with staging and prognostic information. Now, there is still some disease that requires the full axillary lymph node dissection, but we try as much as we can to de-escalate the surgery that we're doing in the axilla. Surgical treatment in the setting of recurrence. So if a patient has had a mastectomy or breast conservation and there's a concern for recurrence, a full workup should be done in the form of a history. So asking the patient if there's any symptoms or if you felt a new lump, when did you notice that? Is there any nipple discharge? Questions along those lines. And of course, the full physical exam. Then diagnostic imaging may be required, such as a breast MRI and a mammogram and an ultrasound. Depending on those findings, a biopsy may be indicated. And then depending on those results, if there is a recurrence of breast cancer that comes back in the results, typically staging imaging would be performed to define the stage of the disease. And again, depending on the stage, the type of breast cancer, is the patient a candidate for any systemic treatment options? Or can we proceed with surgery to treat the breast cancer? When did the recurrence occur? Is the patient a candidate for repeat breast conservation? In a patient who has had a mastectomy and there's reconstruction, a plastic surgeon will typically be involved in that surgical procedure as well. And then what adjuvant treatments are also appropriate. I wanted to also touch on patient factors that influence breast surgery. So a patient's medical history and comorbidities can affect tolerance to treatments. For example, poorly controlled diabetes, there's a higher risk of postoperative complications. Tobacco use, the nicotine can lead to delayed wound healing. Also in particular with the mastectomy flap, it may not heal as well. Nicotine cuts off the blood flow to tissues that are healing. If the nipple is spared, there may be a higher risk of losing the nipple or having nipple necrosis, and then a higher risk of infection. Also, obesity, increased risk of infection, seromas, or fluid development at the surgical site, impairs wound healing, and potentially there's a risk for a hernia at a site, for the plastic surgeon doing tissue-based reconstruction. And patients who had history of a prior stroke and heart attack is also associated with a higher risk of postoperative stroke. And also patients' medical history may influence their tolerance to chemotherapy and if they're a candidate for radiation. So again, along the theme of the treatment plans are very individualized, and it's multidisciplinary care for our patients so that patients receive the best treatment plan and have the best survival outcomes that we can offer as our multidisciplinary team. So with that being said, I'd like to ask if anyone has any questions, and thank you for your time.
Thank you so much, Dr. Krupa. I appreciate that. Very thorough and in-depth description of a lot of things. We've got a couple questions, just a
Sure.
quick one. And that is, what is a mastopexy? What does it mean?
Sure. So a mastopexy, that usually refers to a lift and reduction with a plastic surgeon. So that may be where, say, a patient has a larger breast size and they're interested in having a reduction. So, maybe from my part of the procedure, I would remove the tumor and then the plastic surgeon would do a reduction type procedure so that the patient's breast is much smaller to where they desire, and then also do a symmetry procedure on the other side.
Okay, wonderful. Thank you. Um, so someone had written in earlier today, after having a mastectomy, one breast is hollow at the top as compared to my reduced breast. Is it really worth it to fill the area in, especially since they'd be using some of my skin and tissue?
Um, so I guess it would depend on, so you're probably discussing that with a plastic surgeon, if
Right.
they, what their expectations are for what your result would look like. So I think it's important, how are you feeling how things look, in your clothes or a bathing suit? Are you happy with the result? And with the procedure that they're going to do, will that change anything? What are the risks? What are the drawbacks to it? Um, could it potentially make the problem worse? A lot of plastic surgeons also have before and after images, so that can also give you an idea of expectations. But I would say that that's probably, individualized for you, and based how you're feeling, if you think that that's really worth it for you. And again, with any, like I mentioned, with the prophylactic mastectomy or reconstruction, that can be done at any time. So a lot of, patients who have maybe gone through, chemotherapy, surgery, radiation, just want to, take a break for a year or so and then maybe revisit additional surgery. Other patients want everything all done at once, and that works better for them. So I think really asking the plastic surgeon, okay, this is where I am. What are the expectations? Is this going to get me to where I want to be or not really? Is it not really worth it? Sometimes even a second opinion, of another person too, might be helpful as well.
Mhm. That's great advice as well, just getting a couple of different thoughts on the
Sure.
case. Somebody did write in here, and I feel like this goes along with what you were just saying. How long is recovery after reconstruction? Probably very dependent on multiple factors.
Yeah, so with reconstruction, depending on if there's multiple procedures, I would say at least a couple of months. If it's without, so a flat closure, I say probably about a good 6 weeks, but really depends on the patient. After a mastectomy with a flat closure, so if I'm performing the mastectomy, and plastic surgeon's not involved, you're probably going to be in my office about every week for the first couple of weeks to look at the drain outputs, make sure things are going okay. Then we might space it out to 4 weeks. Probably by the time I see you there, it's about 6 weeks out. Things are going pretty well. So I would still say, from a recovery standpoint for a mastectomy, about 6 weeks. Whereas the difference with a lumpectomy, patients are probably feeling like themselves in about 1 to 2 days and recovery about a couple of weeks. So, the mastectomy is a larger procedure and there can be a higher risk of complications. So again, having that really informed discussion of expectations and kind of what journey we're going to embark on, is really important.
Wonderful. I think you just described
Yeah.
the answer to the next question too that came in. So
Sure.
I'm going to go to one. I know you did discuss it a little bit because it was submitted in advance.
Sure.
But somebody had asked about treatment with a bilateral mastectomy. Implants were done for reconstruction, and then monitoring for recurrence down the line. Can you just give us a little bit as far as what you would recommend as the breast surgeon in that case for recurrence?
Sure. So Since both of the breasts have been removed, routine screening isn't indicated, so you don't need any further mammograms or routine imaging. But per guidelines, we do a physical exam and we see you every 6 months for the first 5 years and then yearly after. So basically, what we're looking to identify recurrence is through physical exam. So is there a skin change? Is there a new lump at the incision site or the flap that wasn't there before? Is there something that was felt in the arm, in the axilla region? And then from there, if there was anything that was found, that would be further worked up with imaging. If a mastectomy was done with implants, we would do a breast MRI. If there's any findings on that, then we would proceed with a biopsy. And then again, based on results of what type of breast cancer, then there would be treatment recommendations. But the risk also of recurrence is very individualized based on the type of breast cancer, the biology of the breast cancer, what systemic treatments were given. So the risk, we do everything with surgery, systemic treatment, and radiation to lower the risk of recurrence to as low as possible.
Okay. So a question here about fluid following surgery. So at a 6-month follow-up, mammogram and ultrasound following a lumpectomy, there was fluid in the surgical area. How long does it usually take for that fluid to be reabsorbed or to go away? The radiologist had said it would go away in the long run. This person is obese and said the fluid could be an issue.
So I would see, usually for my patients, I like to give it time, at least about 4 to 6 weeks to see. Also taking into account if it's causing any discomfort or pain, because sometimes you can do what's called aspirating the area. You can place a needle into the cavity and pull the fluid out, but I'm not in as much favor of that most of the time because it can introduce infection, or if a patient's on a blood thinner, it would make it worse to have a patient bleed into the cavity, in addition to having the fluid there. But most of the time, the seromas do resolve over time. Everybody's a little bit different. So some people, it takes weeks. Other times it's months. But if it's really causing a lot of discomfort and issue, then it can, like I said, easily be aspirated too.
Okay. And for someone who had tram reconstruction, how would they continue to image that breast down the line?
So I would recommend the same with physical exam. And if there was anything that was concerning, we would do a breast MRI. Again, a breast MRI is probably the most aggressive type of imaging. Probably could, if it's a focal area, even just start with an ultrasound, but it really just depends on, what the finding is.
Okay. Are negative margins less likely with a lobular cancer?
Yeah, that's a really good question. So that can be the case because sometimes with lobular cancers, the way that they grow is, so how you can kind of think of them is on a mammogram, a lobular cancer looks like a smudge, whereas a ductal cancer looks like a well-defined tumor. So the lobular cancers, they can be a little bit more sneaky in the sense that on the best imaging that we have with, say, a breast MRI, then, on final pathology, the cancer is larger than previously expected with the best technology that we have. So I think because of the growth pattern of lobular cancers, it is more common to have a positive margin after lumpectomy. But we still, it's still appropriate to have that as an option. But as we kind of talked about, if a patient's had a lumpectomy and then goes back again for a positive margin, still positive, maybe even goes back a second time, still positive, then maybe, having the mastectomy discussion to make sure that we're able to get oncologically clear margins.
Perfect. All right. How often do you see positive margins in a patient with DCIS who ends up having a mastectomy after 2 previous lumpectomies? That's very difficult, in-depth case.
Yeah, I don't know if I have a number. For DCIS positive margin in general, I would say there's about a 15 to 20% chance because so for DCIS, that's where the disease is located in the duct. It hasn't gone outside of the duct in the surrounding breast tissue, whereas invasive breast cancer has. DCIS, it grows by skip lesions. So prior to 2016, if you were to ask breast surgeons across the country, everybody was doing their own thing for margins. So maybe some people were doing 1 centimeter for DCIS. Some people were doing 2. Invasive breast cancer, same thing. So I think it's 2017, there was a guideline that was released that looked at all of the data. And that was how we came to, for DCIS, there has to be at least a 2 millimeter margin because of the way that it grows and skip lesions. So for DCIS, if you do not have a 2 millimeter margin, then the surgeon will more than likely recommend going back to re-excise that area to make sure we're not leaving behind any additional disease. As far as having, that, so again, that could be upwards to nationally a 20% chance. For invasive breast cancer, because it just needs to be a negative margin, there's no number, maybe less likely to have a positive margin. And I think the question was, a subsequent positives. I'd have to look up if there's anything on that, but I don't have a number off the top of my head. But, I would just think, again, kind of similar to the lobular, that it's possible for DCIS to evade, the best imaging that we have. And then there's a larger extent of disease than thought preoperatively.
Yeah, excellent. And we did have a question, if you could define a skip lesion.
So that's where the cancer grows. There's a normal area of tissue, and then there's more cancer. So with the data that we have, we feel comfortable with a 2 millimeter margin for DCIS, that if there is any cancer, normal cancer, you will capture everything if you have at least 2 millimeters.
Okay. Is there a maximum number of lumpectomies that are possible?
So I think this would depend on the situation. So I'm not sure if the patient or the person who submitted the question is asking. So say a patient had a lumpectomy in 1994 and then in the right breast, and then now in 2023, the right breast has another breast cancer. More than likely, so if it's a small breast cancer and depending on the remaining amount of breast tissue, more than likely that's okay. And then okay to get radiation. Again, that would be discussed in a multidisciplinary format. I think after the issue is after a while of getting so many lumpectomies and radiation, from a radiation perspective, what's the cumulative toxicity? And then where does the efficacy of that kind of end? So is the radiation still effective? Mm-hmm. As far as someone who is, another way to answer that would be somebody who presents with disease in multiple quadrants of the breast. Again, that's emerging data, because typically if a patient has breast cancer in multiple quadrants, the thought is that there's then disease connecting those, and there's disease throughout the entire breast. So that patient should be offered a mastectomy. But with what we're looking at, if you have 2 areas and you can get a clear margin and the patient's going to get radiation and your breast MRI does not suggest any disease between those 2 areas, that's probably oncologically safe. So I hope that answered.
Yes. Question. So there's a couple questions that I had as you were going through your presentation.
Sure.
You mentioned the TP53 mutation and kind of the contraindication with radiation. And I had heard the same from several people about the ATM mutation. Is that one that you're familiar with as well?
So ATM is relatively speaking. I think it depends on which radiation oncologist you talk to. but definitely for TP53, there's the risk of secondary malignancy is, unacceptably high. The ATM gene, what I found is depending on which data you look at and who you ask. So that would be, I think, pretty individualized.
Absolutely. And then as you talked about the subtypes, I'm always especially interested in HER2 positive breast cancer. That was mine.
Okay.
And now we've been hearing so much more about a low HER2. And how does that play into deciding when medical oncology would be the first step versus surgical? Do you have any insight on how some of that has changed recently?
Yeah, so that's a really good question because in a lot of the recent conferences and discussion about low HER2, where it first has to start is with the pathologist and actually defining low HER2 from the pathology report, because otherwise we pretty much define, is it positive or negative, on the initial staining. I guess it depends, which center you're at, which test is done first. But would have to start with first defining that disease. And then I think if we start implementing that into clinical practice, those patients should be discussed at tumor board. Of course, we can send, the referral and a patient meet with medical oncology, but I think a meeting of the minds for multiple people to talk about. Because for HER2 currently, there's good data that for HER2 positive disease, less than 2 centimeters can proceed with surgery first and then have systemic treatment afterwards. So I'm not sure for low expression if that will be the case, if the studies will do like a size cutoff. But that is definitely an emerging area for HER2 disease. I completely agree. But that will change the field, not only for surgeons and medical oncologists, but also for pathology. There will have to be a standard of how to define that.
Absolutely. So stay tuned. Everything is changing,
Yes.
as we do know, over time. A question about why are some mammogram practices now requiring a mammogram on breasts that are reconstructed?
I have seen that in some places. It might just be a precedence of how they've always done it, but in their practice, but per guidelines, there does not need to be routine screening. If your radiologist recommends it and it gets done, that's okay, but there isn't anything that shows that will have a better survival if there is a recurrence or pick up a recurrence sooner. So, I mean, maybe in the radiology world, there will be forthcoming recommendations about that, but currently that's not been shown to have, an impact on recurrence and survival.
All right. That's really all the questions that we've got that have come in, but I absolutely want to say thank you so much, Dr.
Yeah,
Krupa,
thank
for being with
you.
us. A big welcome from the Breast Cancer Coalition. And I know that you have an exciting event coming up in just a couple of months. So a wedding.
Yes.
So congratulations.
Thank you.
And we absolutely want to ask everyone to fill out the survey. If there's any questions that you might have, please feel free to email me and I can relay the questions and get some answers. But this was amazing and I look forward to working with you in the future.
Sounds good. Thank you. Thanks for
Thank
having me.
you. Have a great night, everyone.
Bye.